Today is the 1072nd day of the uninterrupted daily webinar of International Forum for Promoting Homeopathy. And today's our guest is Dr. Kulwant Singh. He is the ex-dean, Faculty of Homeopathy, Vinoba Phave University, Hazaribagh, Jharkhand. Principal, Singhbom Homeopathic Medical College and Hospital, Jamshedpur since 2000. Teacher since 43 years. Professor, SHM College, Jamshedpur. Presented several seminars in and outside India. Attended Arab Health Congress, Dubai, 2014. Resource person, seminar, Ministry of Ayush at Vigyan Bhavan, New Delhi, 2016. Resource person, seminar on homeopathy by Central Council of Homeopathy, Siri Forte Stadium, New Delhi, 2016. Resource person, all CC8 workshops in India, have presented several seminars at Ranchi, Patna, Kanyakumari, Trivandrum, Goa, Jhansi, Udaipur, Miham, etc. Ex-chairman, Homeopathy Literature Committee, CCH, New Delhi. Ex-member, Education Committee, CCH, New Delhi. PG Guide, Rajasthan Vidyapeeth, Udaipur. Ex-inspector, Central Council of Homeopathy, New Delhi. Examiner and paper setter, several universities.
Thank you, sir. A very good evening to everybody. And I am thankful to the organizers of this meeting, and especially my guru, my teacher, Dr. M.K. Sahni. And I am thankful for a very special cause that I gave this lecture in Hindi in last 2 sessions. And you have been very kind to be ready to tolerate me again in the same subject, and we'll take 2 sessions. So let us start with PCOD, that is polycystic ovary syndrome. As we see, this is a very, very common problem nowadays amongst females, reproductive age of females, and it is increasing day by day. Up to that the percentage of this problem is nowadays about 12 to 20% in females. It is not a small amount. If a disease is having its issues in reproductive age of females, about 15 or 12 to 20%, it is a very serious matter and matter of concern also. It is one of the most common endocrine disorder in women reproductive age. It is multifactorial disorder which involves hypothalamus, pituitary, ovary, adrenal, and peripheral adipose tissues. This axis where this works and the PCOD develops is known as hypothalamic pituitary ovarian axis. A very small knowledge. This is a normal ovary. In this you can see inside the ovary there is maturation of Graafian follicle. It bursts out, there is formation of corpus luteum, and then it is dissolved or degenerated and the menses appear. But in case of PCOS, you can see there are growth of follicle, but after some time, the growth of follicle is stopped. And after stopping, there are these follicles, small follicles remain inside the ovary, and this is only known as polycystic ovary. You can see in the microscopic picture that these are the ovaries, this is the uterus, this is the fallopian tube, and these are the follicles you can see. These are follicles or cysts. So these are known as polycystic ovary. And what are the conditions which will be present in this polycystic ovary is one of the most important part where it is a matter of great concern, that is infertility. We will discuss everything in detail, but the one thing which is really worries everybody is infertility, enlarged ovaries, irregular menses, high level of male hormones, that is high level of androgen. Why this happens? We will come to that. Excess of hair on the face and the body. This is a problem which may not be painful, but which is very, very concerned. The females are very much concerned because they start getting hair on the face, moustache, chin area, face, like this area. So this is becomes very embarrassing for a female, young female, if she gets this kind of hair on the body. This condition is known as hirsutism. Very problematic area as far as young females are concerned. And this is due to the high level of male hormones, high level of androgens in the system. There is acne, lot of acne, lot of pimples present, and one very important factor for obesity. Obesity causes PCOS, PCOS causes obesity. It's a vicious cycle. If you are obese, you are tend to get PCOS. If you are having PCOS, you are tend to get obese. We'll come to that. Since ancient times, we were aware of the presence of some symptoms which are similar to PCOD, but at that time, this was not diagnosed as PCOD. The Hippocrates, late great Hippocrates, he noticed that there has been a masculine appearance, that they are not concerned about bearing children, nor do they become pregnant. So this is a case where the lady is not becoming pregnant. It means this is a case of anovulation. The menses are not appearing. But at that time, diagnosis was not that on the basis of the appearance of a female. I repeat that these type of females were looking masculine. Very strong, very muscular females who were present and they were not getting pregnant. Soranus of Ephesus, he's a very famous doctor at his times. So he writes that it is natural to, in persons whose bodies are of a masculine type, we observe that the majority of those not menstruating are rather robust, mannish, and sterile women. I want to stress on this fact that at those times, this using 98 to 138 AD, so such a long time back, they were having some knowledge that this sterility, this infertility is related to the females, especially who are looking manly. Mind my words, who are looking manly. The symptoms of male are coming on the females. How? Why? We will come to that. Dr. Ambrose Pade, that is 1510 to 1590 AD, he observed that many women, when their menses are stopped, degenerate after a manner into certain manly nature. That is to say, manly women, therefore, their voice is loud and like a man, and they become bearded. Please note this. They become bearded, which I told earlier also, that the lady gets hair on the moustache, on the beard, due to high levels of androgen, high level of male hormones. So this is basically the observation of these great people who were not knowing about the polycyst or cystic ovary, but they were knowing about the symptomatology of such females. They look like male. Point only one is they look like male, they don't have menstruation. So after not having menstruation, due to the severe hormonal changes in the system, they look like female, male. Dr. Steen and Dr. Leventhal were the great people. In 1935, they observed the ovary. They saw that there were some small cyst-like growth. Please again mind my word, cyst-like growth. But at that time, they thought that they were cysts in the ovary, and they named it polycystic ovary. These people named the cyst-like appearance in the ovary as a polycystic ovary. And at that time, this was also known as Stephen and Leventhal syndrome. For so many years, this was known as Steen and Leventhal syndrome. These were the great scientists. Now, just see the demography, how much this is appearing in females. You can see out of the diagnosed case of polycystic ovary or PCOS, 50 to 70% have hirsutism. So it is so common, so prominent in females who are having some problem with the polycystic ovary, that 50 to 70% have hirsutism. Hirsutism is male-like growth of hair in the body. This looks very bad, very odd, though it doesn't harm the system, but it looks very bad. And in the whole world, 50% of women are diagnosed only. 50% are not diagnosed. In the villages, in the poor areas, they don't know about these things, so they are not diagnosed. Out of 50% diagnosed cases, 50 to 70% have hirsutism. And as I told you, this is an old data, that 5 to 10% are having PCOS amongst the reproductive age. But nowadays, this number is 5 to 15%. And as I told you, that obesity and PCOS are related. So 30 to 70% are obese or overweight. So obesity is a great keynote for the physician to go for a checkup for whether the patient is of PCOS or not. And again, a very, very important point, we will come to that, that is the 50 to 70% of these females are having insulin resistance. The insulin is not properly utilized in the system. So there is an insulin resistance. So the insulin in blood increases. Insulin is not utilized properly in the system. So insulin level in the blood increases. When we will go for the blood test, we will find that insulin levels are high. So I think it is clear. And these 2 points are very important. 30 to 70% are obese, 50 to 70% have insulin resistance. A small introduction of the menstruation before going further, because we'll have to refresh our memory. If otherwise, we will not able to understand the proper pathology of the PCOS. So what happens in normal female, you know, that when there is estrogen level is low, this is the beginning of the cycle. There are 2 cycles in the menstrual cycle. One is follicular phase and one is luteal phase. And in between there is ovulation. And this follicular phase is in uterine cycle also. But first of all, we will discuss the ovarian cycle. This is the ovarian cycle. What happens is that in the brain, from the hypothalamus, there is a hormone secreted known as GnRH, gonadotropin releasing hormone. And this hormone stimulates the cells to secrete FSH, that is follicle stimulating hormone. This is follicle stimulating hormone. Follicle stimulating hormone helps to mature the eggs. The ovary has so many eggs, so many follicles. So out of so many follicles, every month, one follicle will mature. That the one follicle which matures is known as dominant follicle. So one follicle every month matures. This is maturing. Due to the FSH stimulates the secretion of a hormone which is known as estrogen. And estrogen is responsible for the proper growth of the eggs. You can see here the eggs are maturing, but there is a time when estrogen levels are very high. The follicle has matured, the graphene follicle has matured completely. Normally, these follicles are of 2 to 6 mm size, but the mature dominant follicle is about 18 to 20 ml. When it becomes 18 to 20 ml, the intra-ovarian pressure is also increased. So this estrogen level this sends a signal to brain. It sends a negative signal to the brain that now we have enough estrogen, enough FSH. It indicates, it helps, it requests the brain, hypothalamus, to stop estrogen and now secrete LH. So the secretion of FSH is stopped after a certain time. This is follicular phase. And now there is need of bursting of this egg. If the egg will burst, then only the oocyte will come. Then only the egg's oocyte will come out. So this, you see, suddenly there is heavy increase of luteinizing hormone, that is LH. So when the luteinizing hormone is secreted suddenly and more intensely, it is known as LH surge. It is known as LH surge. You can see this is a just blast. It goes to the egg, it blasts the egg, and there is ovulation. This process is known as ovulation. And this process is due to sudden surge of luteinizing hormone, which comes from the hypothalamus. The hypothalamus have two work. One is secretion of FSH, which helps to develop the egg Graafian follicle. Next secretion is of LH. LH goes into the Graafian follicle, bursts it out, and that sudden increase in LH is known as LH surge. If there is no LH surge, there will be no bursting out of the follicle, and the follicle will remain like this. It will not burst out. The eggs will not come out. Mind my words. This is very important in the later part of this. If the LH is not more, if the LH is not secreted properly, if the LH level is very low, it will not burst out the Graafian follicle and the ovum will not come out. We'll come to that. When the ovum comes out, the remaining part of this is known as corpus luteum. This structure from where the eggs are no more, the egg is no more from here, ovum has come out. So this part is known as corpus luteum. And the function of corpus luteum is to secrete a hormone which is known as progesterone. This progesterone goes to the uterine cavity and it helps in the secretion of, secretes substances. It makes the appearance very juicy. Why? I will come to that. But first, when there is a formation of corpus luteum, because the ovum is here, the sperm doesn't come, it doesn't fertilize the ovum. So this part, the corpus luteum, it starts degenerating. There is bursting of ovum, Graafian follicle, the oocyte comes out. There is formation of corpus luteum. Corpus luteum waits for the sperm, so the sperm will come and unite here. If it doesn't come, this ovum, oocyte, this corpus luteum, they start degenerating. And after degenerating, this and this comes out in the form of menses. This is about the ovarian part. What is happening in the ovary? Now, what is happening in the uterus? Both cycles are related with each other. When this is the uterine cycle. The uterine cycle, basically, we are interested with the endometrium, the innermost lining of the uterus. So when there is more FSH, there is more estrogen. And this estrogen goes into the uterus during the follicular phase. And what does it do? What is it doing? It is helping to proliferation of the endometrial tissues. You see, what nature says, that there will be ovum, there will be a sperm coming, there will be fertilization, and the fertilized egg will come to the uterus and develop and grow here. So for the growth of that expected ovum, fertilized ovum, the uterus lining prepare itself. It prepares itself properly so that it may, the fertilized part will come here, will take rest. what we do when a guest comes to our home, we prepare the bed properly, we keep it neat, we have the cushions properly so that the guest is in comfort. So that comfort is given, prepared by the uterine tissues, endometrial tissues, and they start to proliferate, they start to grow, and they become tortuous. They become tortuous, very soft, very tender. So during this period, only due to estrogen, this is always happening. There is proliferative phase influenced by estrogen. The thickness of the endometrial rapidly increases because it becomes soft, it becomes thick, it becomes tortuous, so that the fertilized egg should come, rest here and grow there. Child will develop from here. The fetus will develop from here. But what happens? If there is no fertilization here, no sperm is coming, no fertilization, so what will happen? These linings, which were becoming bigger and bigger and bigger, but very soft, very tortuous, so they start degenerating because the guest has not come. So what will we do? If the guest doesn't come to our house, we will just make the beds again as it was earlier. And we'll keep the soft bed in the albedo, soft. So what happens here is this endometrial lining, this becomes tortuous. These are the secretive of the progesterone, secretions from the progesterone. So this becomes very juicy. The endometrial lining becomes very juicy, and ultimately it disintegrates. And when it disintegrates, the fertilized, non-fertilized ovum, the remaining part of the corpus luteum, and the disintegrated part of the endometrium. These three are the products of menstrual cycle. They come out as menses. And again, the same process is repeated every month. I hope you are very clear about the basic concept of the menstruation, because if you understand this, you will be able to understand PCOS completely. So what we have discussed is that there is a hypothalamus. This is the part of the brain. Please, my request is to try to understand this. So this is a part of brain. This, due to the influence of GnRH, gonadotropin releasing hormone, it acts on pituitary gland, which secretes FSH. This FSH goes to this is the Graafian follicle. So it goes here, it starts secretion of estrogen. And after some time, estrogen also, FSH also help in the growth of this egg. This Graafian follicle is helped by the secretion of FSH. And there is a lot of secretion of estrogen. I told you that estrogen goes where? Estrogen is coming to the uterus. So it is uterus, and you can see these red marks, they are proliferation. There is a proliferation of the uterine endometrial lining. And when estrogen is more, when this matures, what does happen? It sends, you can see, it sends a negative feedback of FSH to the hypothalamus. It sends a negative feedback to the hypothalamus. So what happens? If there is a negative feedback for hypothalamus, so the message is going to the hypothalamus that we have enough estrogen now, so please send some LH. Because now we don't. So hypothalamus or pituitary gland, they stop the secretion of FSH and they start secreting the LH, luteinizing hormone. This luteinizing hormone goes here, then the egg is bursting. It forms the corpus luteum. And there is secretion of a hormone known as progesterone. This progesterone is secreted from the corpus luteum. So progesterone again goes to the uterus and makes these things very juicy, very soft, juicy, tortuous. And if the sperm is not coming here, it is not coming here, this part comes out in the form of menstruation. I hope I am clear. This is the basic concept you will have to understand. Then it will be easy to understand how the polycystic ovary is working. So hypothalamus irritates the pituitary gland, stimulates the pituitary gland. Due to GnRH, there is a secretion of follicle stimulating hormone. When it secretes estrogen, estrogen helps in development of the Graafian follicle. After a certain age, time, the estrogen is not required. So there is a negative signal to hypothalamus, stop FSH, send LH. Now LH is being sent here. LH goes to here. It stimulates the Graafian follicle and it bursts out. And after bursting, the egg is released and the remaining part is known as corpus luteum. Corpus luteum secretes progesterone, which is helping in the secretory part of the endometrium to grow properly so that the fertilizer can come. If there is no fertilization, if the sperm is not going there, what will happen? This will come out in the form of periods, because now these parts, the endometrial part, has become very juicy, very tortuous, very weak. Am I clear?
Yes.
No.
We are getting.
Thank you. Now we'll come to causes and diagnostic criteria. What are the causes of PCOS and what are the diagnostic criteria? Very important part. So there is a Rotterdam criteria. This is an internationally accepted norm for diagnosis of PCOS. It is known as Rotterdam criteria. You can write now the spelling. Rotterdam criteria. So 2 out of these 3 things must be present when we want to diagnose a case of PCOS or PCOD. The number 1 is menstrual irregularity due to anovulation or oligoovulation. That is, anovulation is if there is no ovulation, there will be no menses. So anovulation or amenorrhea. Oligoovulation is menses in after 3 to 4 months. So 3 to 4 periods in a year. That is oligo, less. That is less ovulation or anovulation, menstrual irregularity. That is the first point when we'll have to discuss or think about this. The second is evidence of clinical or biochemical hyperandrogenism. Please try to understand. These words are very important. There is evidence of hyperandrogenism, either clinical or biochemical. So biochemical means when we go for some specific blood test, we will find that there is a hyperandrogenism. Or in simple language, the testosterone level will be high. In a female, as testosterone is the male hormone, but in a female, we will find that biochemically that the testosterone level is high, which is known as hyperandrogenism. This is clinical, biochemical, by the blood test. But one is clinical. So clinical hyperandrogenism is known by 2 to 3 special signs. 2 to 3 special signs by which, without going for a blood test also, we can say that clinically this is a case of PCOS, or this is a case of hyperandrogenism where testosterone level may be high. What are these signs? Number one, I told you hirsutism. The most important sign on the skin is hirsutism, that is excess of hair growth or man-like hair growth in a female. The second sign is severe acne. Severe acne on face, shoulders, violent acne. This acne is also due to more testosterone, because there is more testosterone. We'll come to that later. And third is presence of polycystic ovaries. What happens when small ovaries, graphene follicles, which are not maturing properly, what do? They arrange themselves around the border of the ovary. So if they are arranged around the border of the ovary, it looks like a necklace of pearls. So that is known as the string of pearl sign. I'll come show you ultrasound also. So these are the three signs. Plus number 3 is presence of 12 or more follicles, preferably 20, in each ovary, measuring 2 to 9 mm in diameter. The size of the immature graphene follicles should be between 2 to 9 mm, because the mature graphene follicle is 18 to 20 mm. 18 to 20 mm, it will not grow up to 18 to 20 mm. The growth will be up to 2 to 9 mm in diameter. So due to this, several graphene follicle, immature follicles, the ovarian volume will increase. Normally, the ovarian volume is 10 ml. So these 3 are the points. 2 of the 3, if possible, if present, it will be known as a case of PCOS. So now please note that these 3 are the symptoms, signs. So if 1, 2, 3, all 3 are known, present, then also there will be PCOS. If 1 and 2 are present, then also it will be PCOS. Then if 2 and 3 are present, then it will be PCOS. If 1 and 3 are present, then also it will be PCOS. So there are 4 phenotypes of PCOS if we want to diagnose a PCOS case on the basis of Rotterdam criteria. 1, 2, 3, 3 present, all present, 1 and 2 present, 1 and 3 present, 2 and 3 present. So these are the 4 phenotypes where we will find the presence of PCOS. Either of these, as I have explained you, 1, 2, 3, all 3 present, 1 and 2, 1 and 3, 2 and 3. In all these cases, we can say that this is a case of PCOS. Diagnosis of this can be done on the basis of this. Now, what happens? This is a normal phenomena of basic hormonal changes during a normal menstrual cycle. If you can understand this, you will understand everything. I told you that this is 0 day starting of, after finishing the starting of period cycle. This is 14 ovulation day. This is 28 finishing of the periods. So you can see that follicle stimulating hormone, this black line is follicle stimulating hormone. The secretion of follicle stimulating hormone is going at a normal speed. And this normal speed of follicle, see the chart carefully, this normal speed is helping to mature the graphene follicles. You can see here, the FSH starting, it secretes estrogen. Due to estrogen secretion, there are very, very small follicles, and one of those follicles will mature. We know that every month only one egg matures. Only one graphene follicle matures every month. So one of them, the smartest graphene follicle, will mature. Others will not mature. Others will either disintegrate So there are so many small follicles. One of them is maturing. This is known as Graafian follicle. Before coming to the ovulation phase, that is about almost 14th day, what happens? The FSH becomes slightly better, but there is, I told you in the last slide, that there is sudden surge of luteinizing hormone. There is sudden surge. Achanak, this LH is normal. Achanak, suddenly it is going up. And then again coming back to normal. So this going up, this sudden surge of luteinizing hormone causes bursting of Graafian follicle. Sudden surge of luteinizing hormone causes sudden surge. This causes ovulation and Graafian follicle bursts out, and there is secretion of corpus luteum. And this corpus luteum, you can see there was estrogen. Estrogen was maturing. Please note, there was secretion of estrogen due to FSH. The estrogen was becoming high. And at one place, the signal goes to the brain that, boss, we have sufficient estrogen. Now, please stop sending estrogen and please send LH. So at this stage, when the estrogen level high, the brain stops secreting FSH. It stops estrogen. It comes down and the LH is rising here. And due to LH rise, it is bursting out. There is formation of corpus luteum. And when there is formation of corpus luteum, it secretes progesterone. You can see this progesterone. The progesterone level is coming normal. But after the corpus luteum is formed, it increases a lot. And at the time of finishing of the period, this comes down again. And what does this progesterone do? This, I told you that estrogen, they start in the uterus, they start proliferation of the linings. Uterine lining is proliferating, and you can see this uterine lining has started proliferating. Due to the action of estrogen, this lining is proliferating. This is becoming bigger, longer, bigger. So as the time passes on, the uterus lining is becoming longer and longer. And before the periods, when there is, due to progesterone, due to LH, these things are maturing. But gradually what happens? There is more and more of blood supply. They become tortuous. And at the end of the period, this full of blood and secretions by help of progesterone. The lining has become such big. This is the start. This is the end of period. So they have become bigger, and very tortuous, very juicy, very full of blood. And gradually when there is fall of progesterone, the sperm has not come, it has not united with the ovum. They shred. These things are shredding out. They are bursting out, they are shredding out. The endometrial wall shreds these things, and this becomes out as the menstrual period. This is the basis of the normal hormonal function of follicle stimulating hormone, luteinizing hormone, progesterone, estrogen. And if we can understand this, we will be able to understand the PCOS completely. Because as a homeopath, we know there are several medicines for PCOD. We can give so much, but nowadays what happens? The patient is more qualified than us. If a patient is diagnosed as PCOS, she will come to you with all consultancy with Dr. Google. And Dr. Google will explain him everything, that this is the cause, this is the cause, this is the cause. So she will come well prepared about these things, and she will ask. She will not only take medicine from you. And we cannot say, oh, we are depending on the symptom similarity and the homeopath can prescribe only on the basis of symptoms. You don't worry, you will be all right. Nowadays, it doesn't work. At least in my practice of 43 years, nowadays I am marking that this doesn't work. People come with the report, people come prepared with all the data. So you will have to explain them why you are having this. What is the basic concept? They will ask you what is estrogen, what is progesterone, how, because they have studied. They may not have understood everything, but they know the names. And they want to know the causes, proper causes, that why it is happening. I hope I am very clear in these things, that what is the basic of menstruation. Now, what happens in the formation of PCOS? Do you have time today? So this is what happens in PCOS or PCOD. One very important fact which I would like to tell you, that the name PCOD, polycystic ovarian disorder or disease, or polycystic ovarian syndrome, now the name has been accepted that it is a non-polycystic ovary. Please take it a note that now it is known as non-polycystic ovary, because the graphene follicles, they are not cyst. In the initial, Dr. Steen and Leventhal saw, they named it as a polycystic ovary. The medical science, respecting them, accepted that. But nowadays, it is not known as proper, it is known as non-polycystic ovary or poly-non-cystic ovary. These are follicles, these are not cysts. So be prepared. If somebody asks you, you can answer that this question, why it is known as non-polycystic. So what happens here is, due to hormonal problems, the follicle stimulating hormone is not being secreted properly. This starts from this point. This is the pathology of PCOS, very, very important. So this is a small, due to the low level of FSH. You can see this green, blue lining is FSH. There is no change in the secretion of FSH. You can see it is going straight. So number one, the FSH secretion is low. Follicle stimulating hormone is low. So what will happen? The name indicates, if follicle stimulating hormone is not there, there will be no stimulation of the follicle and there will be no growth of the follicles. So what will happen? The small follicles will come, they will grow a bit and then stop. You can see there are so many small follicles. Am I clear? There are so many small follicles, but they are not growing. The grown follicle is, I told you, 18 to 20 mm. These are only 2 to 6 mm. So there are so many small follicles which are trying to grow, but due to lack of FSH, they are not growing. They are become small, 2 to 6 mm size, but there are multiple graphene follicles which are not. But what happens? If there is no FSH, there is no estrogen, which we have discussed in the last slide. Please consider that FSH is for estrogen, LH is for progesterone. Up to this, I am clear? In the last slides, yes. FSH is responsible for estrogen secretion, LH is responsible for the progesterone secretion. So if there is no FSH, there will be no estrogen. So there will be no estrogen. But what happens that all these multiple small follicles which are not growing, but they have small amount of estrogen. Not up to that level by which one molecule or one graphene follicle will mature completely. But they are having small quantities of estrogen, and combinedly the estrogen secretion is more. So combinedly, all these follicles, you can see the estrogen level is going high. Normally what happens? When the FSH is high, then the estrogen level goes high. But in this case, the FSH is the normal level, it is not increasing. But due to the presence of a small amount of estrogen in each follicle, the amount of estrogen is becoming more. This is progressively increasing, not knowing what is happening in the FSH. But due to the presence of this only, they are increasing. But as every egg, every follicle is trying to mature, but it is not able to mature. It will try to mature, but it will not mature. As a result, they become hard. The graphene follicles, they become very hard. And due to this hardness, they look like a pearl of string, which I will show you. So there are small follicles, they do not mature, but estrogen is very high. So when the estrogen is very high, it is sending a signal to the brain that I need LH. Am I clear? When the estrogen is high, it sends a signal to the brain that please send LH. So now they secrete LH, the LH becoming high. But what is the function of LH? LH helps to burst out. LH surge helps to burst out the graphene follicle. But there is no mature graphene follicle. Is it clear? There is no mature follicle. So LH will try to come here, burst out, but there is no bursting out of the follicle. So LH doesn't work. And sir, if there is no bursting of the follicle, there will be no corpus luteum. Am I clear? Graphene follicle bursts and then it forms a corpus luteum, and then the corpus luteum starts secreting progesterone. So if there is no bursting of the graphene follicle, there will be no formation of corpus luteum. And if there is no formation of corpus luteum, there will be no progesterone. If there will be no progesterone, it won't go to the uterine endometrium and there will be no secretion. There will be no secretion. So, jo hota tha pehle, what was happening, that there was secretion of the endometrium, there was fully bursting of the endometrium and degeneration of the endometrium, and blood was coming out as menstrual period. But in this case, due to high progesterone, it will try to burst out the follicle is not mature, it will not burst out, and there will be no corpus luteum coming out from the graphene follicle. If there will be no corpus luteum, there will be no, tell me, progesterone. If there is no corpus luteum, there will be no progesterone. There will be no progesterone, it won't go to the endometrium and not mature these things. But in the meantime, what is happening? The estrogen is becoming high. So if the estrogen is high, what was the function of estrogen? It was going to the endometrial lining, it was going to the uterus, it was trying to mature the endometrial lining. So due to estrogen, these are the endometrial lining, they are maturing, they are become bigger. This is 14 days, 28 days, 60 days, 90 days. But there is no progesterone. So there will be no progesterone. There is no graphene follicle bursting. There is no ovum. So there will be no pregnancy. There cannot be pregnancy. That is the reason why in PCOS you get an ovulation. Ovulation is not happening. If ovulation is not happening, the proper mens will not happen. And if the proper mens will not happen, there will be no pregnancy unless and until there is a mature follicle which bursts out, oocyte comes out, corpus luteum forms, and the sperm goes and meets the graphene follicle. This is not happening here. So obviously, the patient will have infertility. No mens, no ovulation, the patient will be not able to fertile. So there will be infertility is main reason in PCOS. The patient will come to you, a young female will come to you, the doctor, what I am having is and I'm not having menses for 2 months, 3 months, then again I have some bleeding. She will say that the menses starts, and after 10 days again the menses starts, and after 10 days again the menses starts, but again after 3 months this process is repeated. What is happening? Why this is happening? These are not menstruation. This is purely uterine bleeding. This is not menstruation. What is happening is that these endometrial wall, they are becoming mature, mature, and mature. So the lining becomes longer. The endometrial lining is becoming longer. This is after 2 months. This is after 3 months. This is after 4 months. So as the lining is becoming longer, the system, the human system, is not able to pump the blood to this height. Very natural. Normal endometrial lining is this thick. Now it has become this thick, this long. So what happens that the blood doesn't go up to the top level, and there is ischemia. There is lack of blood supply here. This is 120th day. So there is lack of blood supply, there is ischemia, and this part will disintegrate, degenerate, and there will be bleeding from the uterus. There will be bleeding from uterus here. So after 60 days, 2 months, 3 months, 2 months, 20 days, there will be bleeding from uterus due to this, due to ischemia of the endometrial wall. There is no ovum, there is no Graafian follicle, there is no progesterone. But only due to this reason, the patient will have bleeding off and on without having any mens. Is it clear? So this is the reason why this patient will have problems and the symptoms like this. Next webinar, we will discuss the remaining part and the medicinal part, how we will manage the PCOS. And thank you very much.